This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent of the AARC. Copyright 2012, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on the art of teaching at the bedside. The learning objectives for today's session are to cite important key principles of adult learning applicable to bedside teaching, describe past and recent history of bedside teaching, discuss the advantages and challenges to bedside teaching, describe strategies to improve teaching on rounds and at the bedside, and describe effective techniques for bedside teaching. I am pleased to introduce Susan R. Johnson. Susan is a registered respiratory therapist and holds a Master's of Education degree. For the past 7 years, she has been an instructor in the respiratory therapy program at Georgia Health Sciences University in Augusta, Georgia. For the past 5 years, she's been the Director of Clinical Education at Georgia Health Sciences University. She is the presenter of a preceptor program which all respiratory therapy clinical instructors are required to successfully complete. Ms. Johnson discloses she has no conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Susan, welcome to the program.
Thank you so much, Bill, for the kind introduction. First off, I want to wish everyone out there a happy Respiratory Care Week. Thank you all for your contributions to the profession, and what a great week to celebrate what we do. So first off, I want to give you a little bit of background information on the preceptor discussion that we're going to have today. We have preceptors here that we actually utilize, with the economy the way that it is, kind of do more with less. So we've had to branch out of our traditional roles as faculty and really identify key individuals within the clinics that we use to help us with student learning and clinical learning. So we have open dialogue and different discussions with some of these individuals, really reached out and said, what are some things that you need? And so to support what they do for us, they have asked us to come up with some supportive measures and some teaching, some history and ways that they can better do their job at the bedside. And so one of those key elements was taking the book traditional teaching, classroom education to the bedside. And how do they do that? So first off, qualities of an effective preceptor. What is a preceptor? Often a preceptor is a teacher, and they're very similar. Teachers traditionally have been in a classroom. You have desk, you have students, you have face-to-face, so you're able to read the nonverbal communication. Well, preceptors are the same thing. They're teachers in the clinic. So to begin any teaching and student learning, there has to be a relationship. So with that relationship, you really should choose preceptors that or identify preceptors that want to teach. Not because they get an extra dollar, not because this is a role that they have to partake in. Truly needs to be someone that has the opportunity to teach these students. With that, there's so many things that can be done, We can grow people that are motivated, that want to do this, that want to have a relationship, that want to have an effect on these students. So good communication skills is key. Being able to adapt to a diverse population of adults. Traditionally, we had students that were often under 25, straight out of high school, going into college. So their ability to learn was a little different than the second year or the third year or the fourth year or even a second career student that's in their 30s and 40s. So being able to adapt to this huge population, being very diverse. Intuitiveness, being able to read, okay, what's going to happen next? A solid foundation of knowledge. So taking a preceptor that's early in their experience, early in their career, is often a little more difficult to train and to really use and to utilize their skills. So you really want someone that's had the experience, that can combine the book knowledge with the experience that they've had. So having some resourcefulness, being able to know the hospital, know the documentation center, really know the setting in which they're in, and being able to have clinical reasoning, being able to have good communication skills with the physicians, other healthcare professionals, and really utilizing those skills. Psychomotor skills, you know, I typically say it's often hard to teach an old dog new tricks, but we can do that. So a relationship between cognitive functions and physical movement. This is psychomotor skills. An example of that would be riding a bicycle. The first time that you did it, of course, you had to think about what you were doing. You had to think about pedaling. You had to think about steering. But as you develop these skills over time, that thought really becomes habitual. You get on it, you know how to ride the bike. And then from then on, 10 years later, you can still ride a bike. So another reason in the clinic, or another example, would be a breathing treatment. How many of us can set up a breathing treatment with no thought process? It's just something we've done so often. It's a habitual thing. It's a psychomotor skill that's been developed, and we know exactly what to do with very little thought. So honing in on these things and really allowing the student to sometimes watch what we do says more than actual words can. So when we look at preceptors and we look at students, what is the audience? Who is our audience? And really, whether you're a faculty member, whether you're an instructor in the hospital, whether you're a supervisor, a team leader, or a staff member, all of us play a part in precepting, whether it's choosing your preceptors, whether it's giving the supervisor, giving the support to the staff that has students. So we need to understand what kind of audience we have to have a better control over how we react. And so some emotional factors in adult learning is very, very different from emotional factors in say, children. So three main things that really need to be accomplished when you're looking at adults. The self-concept, seeing themselves as capable of self-direction and desire others to see them that way. They're adults. They don't necessarily want to be told A, B, and C every single time. So you give them a little bit of that distance so that we, as a preceptor or as a faculty member, can see them act on their own without having to have their hand held. Motivation, to learn what they have a need to do so, and desire to know that training would help. So what's their motivational level? Where are they? And when you look at motivational levels, you can really get in depth there, because what are they bringing with them? These are adults. Many things impede adult learning, especially things that they bring from home. So social environments and things that happen at home, family. Prior to entering into that clinical arena, they really can bring lots of baggage, and motivational levels can change. So really determine the benefits of what they're learning, and have that open dialogue with them, build a relationship so that you can understand where their level is. And reinforcement. Often, you know, many of us, especially as professionals, that pat on the back sometimes doesn't necessarily come. As preceptors, as faculty, as teachers, reinforcement is a key element in having that adult say, okay, I've learned this, I'm doing well, I can move forward to the next thing, or to the next struggle, or to the next objective that they need to reach. So reinforcement is truly key, and it's positive reinforcement that seems to make the most difference. So don't forget to say, yes, you did a great job. Intellectual factors in adult learning, many things come into play, and again, we're not dealing with the traditional college student that we used to have 2 decades ago. Often now, a diverse group of students that we have. Typically here, we'll have more than 40 or 50% of our students that are over 30. They have jobs, they have family at home, they have children at home. So learning their level of knowledge and experiences, and having that, again, relationship building, being able to be intuitive and to see where they are and how you can make them grow. So previous learning possesses a large bank of knowledge, so they bring so many skills to the table when they're in this. And interpersonal relationships with the patient is key. And an example of this is I've had recently an actual student who used to work, she actually worked in the fast food, so she was basically a waitress, and she great communication skills, could talk with anyone, bedside manner was awesome, and I actually stepped away and learned from her. So being humble enough to allow the intellectual abilities of your students sometimes rub off on you. So allowing that open piece and again the reinforcement and saying, hey, you're doing a great job. Stepping away, I literally stepped away and said, what you just did in there, I actually took so many things away from that. So learning the intellectual factors and seeing where each one of these students are coming from. Another thing that I think is key for preceptor relationships with students as being adults is having repetitive rotations with them. A hit and miss rotation, if you have a student one time and one time only, it's very difficult to really evolve and bring these interpersonal relationships in and be able to give great feedback to this student. It's hard to develop these things in one 12-hour rotation. So really forming a relationship, having multiple rotations with the preceptor, I think is key for developing that student. Best learning, old linked with the new. Again, these are adults. They're going to bring their own experiences in. Sometimes this can be a difficult thing. Learners may dismiss or reject new knowledge. Again, that can't teach old dog new tricks. If they've learned it one way in another setting, in another situation, multiple times, they're going to be a little more narrow-minded. So sometimes giving them the why and the background information is key to allow them to open up to a new way of doing something. Passive versus active learning, and this is based on a couple of studies. For adult learning, 10% say adult typically retains 10% when they read it, 20% when they hear it, 30% when they see it, 50% when they hear and see, 70% if stated out loud, and 90% if they state it while they're performing it. So I think this is key as well. And one of the things that I often do, or that I suggest when preceptors have the time, is to tell, you watch one, you do one, and then you teach one. I truly take that to heart, and I think it's very difficult to know something from beginning to end, the ins and out of everything, unless you teach it. That's when you really learn it. So I have a lot of my students that are seasoned, that are really good in certain areas. I use that to my advantage. I allow them to teach other students. Of course, I'm there with them and kind of overseeing the process to make sure everything is smooth. However, arterial blood gas. Let's say I've had one student that's had the opportunity to do 10 blood gases. They perfected it. They do an awesome job in it. Their steps have become strategic, and they're very standard, and they do a good job. I have a student that might have had one or two and still very shaky, still very nervous. Having that seasoned student that has perfected this and really good at it, take the other student kind of under their arm and say, okay, take them under their wings. They go in, and I'm there, and I listen, but I allow these two to teamwork. I allow the seasoned therapist or the seasoned student to teach the student that is really weak, and it's a great relationship, and it's a great way to team build. It's a great way to allow the student that seems to be seasoned in this to really perfect it even more, and it builds respect among the students. So it builds respect among the colleagues of them. It's a great way to really etch in that memory in the brain of what they're performing. So now they're performing it, and they're also stating it out loud. So 90% is retained. So that's an awesome way to not just allow them to learn it, but it's an awesome way to teach at the bedside and assist you in the learning environment. Learning preferences. What appeals to one may not appeal to another, and this is so true in the adult world. Personalities are everywhere. You have cultural differences. Again, you have such a wide variety of age groups. So the learning setting, social needs, learning style, and again, motivation. Motivation, I think, is key, and what they bring in from the outside. Now, one of the things that I do when we're talking about what appeals to one may not appeal to the other is if you have a group of students, or you have one group at a time, whether it's 1-on-1 or 2-to-1 or even 4-to-1, which we have at times, it's taking that person that is the introvert, that's not outspoken, and having them think or function outside their box. It gives them a diverse knowledge, a new skill set, and allows them to work on areas that they're very, very not secure with. So kind of bringing them out of that shell, and then the opposite of that. The student that's the know-it-all, that knows everything, has done everything, and we all know who these are. Bringing that student down, allowing them, learn some humility, allowing them to take a break, be quiet for a moment. Let your visual sense kind of hone in and tell you what's going on. So an example of that I've done with these type of students is go in and just say, okay, before we even enter the room, as we stand at the doorway, I want you to just be quiet. Don't say a word. I don't want you to look. After we do whatever procedure we've done and we take away, I'll say, what did you see? What things did you pick up? What did you see with the room? So what were you able to observe? So these assessment observation skills are key for individuals that tend to know everything. They're talkers that say way more than they should and never sit back and listen. So taking students that have these set learning preferences kind of out of their box some. Allowing them to be in that unfamiliar area. Sometimes it's kind of that sink or swim, and they have to learn other ways to adapt. Being autonomous and self-directed. So adults, again, they're not like children. You're not going to hold their hand every time. You're going to direct them. You're going to help them. You're there for support, but they need to be able to do it themselves. That's their way to build their confidence. They need to be free to direct themselves. And one of the things I like to say is, you guys, most of you remember when you were a student and you had that one professor or that one teacher that was standing over you. They were your shadow 24/7 in the clinic. How nervous did it make you? Your hand's shaking, your voice is shaking, you can't seem to perform your normal routine duties that you would do even in assessment. And as soon as that instructor or that professor walked away, everything totally changed. You're able to communicate with the patient better, a lot more effectively. You're able to do your job. You're able to go through your standard procedures as far as assessment skills. Everything just completely changes. So I like to, and I encourage a lot of the preceptors, is once you've formed a relationship with these students or you're into half a day, allow them to act on their own. Don't be a shadow. Don't stand over their every move. Allow them to make some of their own moves without you holding their hand. This gives so much encouragement to an adult learner especially. It gives them a moment to be self-directed, to stand alone and do what they've been taught. You have to engage, you have to facilitate, you need to be there for support and for guidance, but you don't have to be the one that says, here, stick the needle here. Here, you don't have the mask quite on right. Whatever the procedure is, if it's a ventilator check, allow the student, sometimes even not necessarily anything that would harm the patients, but sometimes to kind of swim a little bit and figure out where they need to go. It's a great ability for them to gain some confidence and the ability to know that they stand alone, which I do think is key. They are goal-oriented, and they have to know that what they're doing is relevant. And this is where the big question of why comes in. One of the things that I think we've made the mistake in this profession is being so task-oriented that everything we do is based on numbers, procedure count, how much time, and of course the bottom line, money. Where's the question of why, the critical thinking skills? We have to know the goals. We have to know the objectives of what we're doing and why we're doing them. But is it necessary? Is it truly needed? So always leave room for what you're doing, the application of what you're doing, and why you're doing it. So you want to set responsibilities, make it valuable to that learner, make it valuable to that student, understanding the why. Not just go in and perform arterial blood gas, not just go in and have a task of 14 jet nebs in a day, but go in and say, why are we giving this? What's going on with the patient? Do a quick SOAP note, an application of a SOAP. So have them understand, and that will give, when you're teaching old dogs new tricks, that will give them that open mind. Okay, I understand now. I understand why we're doing this. It's not just a task that must be completed. So some adult learning principles, ideas, feelings, actions. As adults, we all have this play into a part. It's a cognitive, affective, and psychomotor again. So you have to give attention to all these. Allow the adult learner to express their ideas, express their feelings. One of the things that I think this is key in when you're talking about expressing feelings, often we forget there's an emotion to clinical practice. There's an emotion to taking care of people. They're not just patients. They're actual people. They're mothers, their daughters, their family members. So we get, again, so task-oriented and so driven on what we're performing, we forget to step back and take care of the patient. So when you have these new students in, emotions play a key part. Many of them have often not been a part of a death, not been a part of a birth, these huge life-changing situations, and they often are very, very emotional. So allowing that student of what is often so taboo in the clinic to have an emotion, that it's okay. Again, the relationship piece and the people skills with these students, and allowing them to express what they're feeling. Is it wrong? Is it right? And I've had students say to me, you know, you guys seem like robots. Speaking about us as clinicians, you guys seem like robots. How come I've never seen you shed a tear? How come, you know, you go through these major life-changing situations for these families and for these patients, and I've never seen your emotion change. It's always professional. Well, allowing them to express that and giving you an opportunity to explain where you've been and where you are now. We all had emotions when we first saw this. We all often took them away with us and weren't necessarily expressed. So having that touchy-feely piece in a student relationship allows them to express these things that can often be a barrier to the learning. So I think feelings and emotion is a key part in the student learning at the bedside, at understanding what that student's going through and giving them the opportunity to express it. So that's a little bit on adult learning and kind of where the adult learning situation comes from in compared to children learning and adolescents and even young adults. So when you have a diverse group of adults and looking at all of their situations and all of the knowledge and baggage that they bring from other areas of life and how you can help develop them. So taking that to the actual bedside, and how can we take the knowledge they're learning in the classroom to the application of it at the bedside and still combine and have a teaching moment. So this we didn't always do this, and it really stems back, to give you a little piece of history here, to Hippocrates. So the principles of the Hippocratic method, he wasn't just a teacher of medicine. You know, he was a practitioner, and he traveled, and he actually taught a lot from his bedside. He had two huge principles: observe all and study the patient rather than the disease, and reflect the important role of the patient in his teaching. So he was really the beginner and the pioneer of this entire teaching at the bedside. So in essence, what he was saying was, can you study a patient versus studying the disease? And you guys know that none of us function in black and white. We live in gray when it comes to the clinic. No patient is going to have the exact same symptoms, the exact same signs, and they come with so many comorbidities now and so much history. So in the classroom, we learned that black and white piece. We learned what COPD is. We learned the exact pathophysiology of it. We learned exactly how the chest x-ray should look. But in the clinic, there's very little exacts. So having to study the patient and learning how we take these things that we've learned and how we adapt them some based on individual patients. Hippocrates really, he kind of helped perfect this piece. And I think it's important to still continue to utilize that in today's world. The next person that I think was extremely helped mold teaching at the bedside was Sylvius. One of the things he did in the 17th century, he was famous for naming the Sylvian Fisher. So he wrote about his approach a lot. He did a lot of writing when it came to teaching at the bedside, and he had one of his quotes that I love was, "My method is to lead my students by hand to the practice of medicine, taking them every day to see patients in the public hospital, that they may hear the patient's symptoms and see their physical findings. Then I question students as to what they have noted in their patients about their thoughts and perceptions regarding the causes of the illness and the principles of the treatment." So creating that open dialogue piece, what one student may see, what another student may see, and their perception of that may be totally different, totally different. The same thing goes with the preceptor. The preceptor takes a student in, he sees one thing, the student sees another thing. Without having that communication and that open dialogue, the learning experience could be lost. So taking away outside the actual classroom, having a conversation, we'll talk about where these conversations can take place in just a few moments, about what they saw, what their perceptions were, especially if there's more than a preceptor and one student. This is great and can be very useful when you have multiple students in the same learning environment. So learning what one student saw versus another student, and how there's that aha moment of, oh, I didn't realize that. I didn't see that. My observation was totally different. It's a great opportunity to learn. The next historical piece is Sir William Osler, who considered one of the most important clinicians and medical teachers in the U.S., Canada, and England. He spoke also, but he wrote at length about the importance of teaching at the bedside. He said, "How can we make the work of the student practical?" The answer is, take them from the lecture room, take them from an amphitheater, put them into the bedside. Let them observe what they're being taught. So he thought it was key and thought it was important to, again, etch that memory and learn the experience of the patient. Helps them better adapt and helps them be a lot more intuitive about future patients. He played an important role bedside teaching. Teaching in the presence of the patient is reflected throughout the history of medicine. And this even continues today. So in today's world, while it might be a little bit different, we'll talk about some of the reasons I think we may have some barriers, but around 1964, we had a little less than 20% teaching time in the presence of a patient. So that's truly at the bedside, where the patient can hear what you're teaching, what you're saying. Around 1978, about 16%, and now, that's a big question. I'd venture to say with some of the modern technologies, you also have shortened hospital stays, so your length of stay is decreased, increased acuity of illnesses, so many comorbidities, new documentation. We have so many now with new technology. Documentation has changed nationally in the last decade from paper charting to computer charting. There's so many pros and cons about that. So I think it's doubtful to say the amount of teaching at the bedside has increased really since 1980 or so. I think, if anything, it may have gone down just because of mostly time. And we're going to talk about how we can change some of that, what we can do with a limited amount of time. So again, challenges and obstacles. First one that I just said, time. Time is probably one of the biggest, most significant challenge that we have nowadays at teaching at the bedside. Also patient-related concerns. Do learners like it? And teachers' concerns. So if you're the actual preceptor or the teacher, what are your concerns for this scenario, this situation of teaching at the bedside? Overall, patient-related concerns as well as the learner, they seem to value it. even a patient. One of the new, I guess, trends of healthcare is that patient-family interaction, care where you involve the family as well as the patient. And if you can educate the patient at the same time you're educating your students, why wouldn't that be an awesome learning environment for all involved? So patient-related concerns tend to err on the side of time. And we'll talk about what's really key to do in front of the patient and when certain things need to be taken outside the room and not necessarily in front of the patient. And then a teacher's concerns. We're going to explore some of the things that teachers feel and what makes them a little uncomfortable in playing that role of the bedside. So what needs to happen? When you're standing at the bedside and you have the student learner, what really needs to happen? You need the learner, you need the trainee, and then you need questions. You need to question whatever the patient's going through, the signs, the symptoms, the actual what you're in the room for. If this is just a patient exposure interaction, whether you're just doing a typical assessment, but you're not performing any kind of task, that's a great way to introduce a new student learner to the patient. To have that patient interaction where there's no stress to perform a breathing treatment or even oxygen therapy or even very basic respiratory therapy care. So we're not performing care and just truly having patient or interaction. Just an open dialogue, maybe listen to breath sounds, observe what's in the room. It's a great way to introduce a new learner into the environment of teaching at the bedside. And it's a great way to have that interaction with the patient. Hey, I have a student here, and we're going to come in and just ask you a couple of questions. And most patients, most of the time, would say, yeah, I'll love to have a student come in. And at times, you almost have to cut it off because the patient gets so involved in wanting to teach the student about their disease, about their symptoms, about their struggles that they're having with the reason they're in the hospital. So it makes the students so much more comfortable to know that that interaction can exist, and they walk away with such a comfort level and knowing that the support from the patient is there and the learner is there. And it's a level of truly of just comfort. That whole piece of being nervous and making sure they perform what they're doing correctly is kind of taken out. So to grow with that, once that's been kind of accomplished, the next level is to actually do something where they have to perform. Whether it's a blood gas, oxygen therapy, treatments all the way up to very invasive procedures. Stimulating the patient, the student learner to think about what they're doing and trying to make it a nurturing environment where they don't get so nervous and so wrapped up in the questions that they forget to perform correctly. Again, that level of comfort and good relationship building between the three. And when I say three, I mean the preceptor, the student, as well as the patient. Encourage the progress, encourage the the student to make sure things are going well, pat them on the back, yeah, that's right, okay. And a lot of times what I do is jump in and we'll have like a team, we'll have a team approach to the patient. Whether it's a breathing treatment, I'll help the student set up the actual apparatus while they're getting the medications, they're doing the patient assessment. I'll ask them, okay, what liter flow do I need to turn the flow meter on? Here's the mask. Okay, you put the mask on. And then again, what did you hear? As the patient's doing their breathing treatment and we're coaching as far as deep breathing, when you listen to breath sounds, what did you hear? What specific area did you hear that in? And then I'll listen and I'll say, okay, and I'll never ever condescend or put the student down in front of the patient. I think that's key. That's knocking them down 4 or 5 levels of confidence when you actually step in and you do something like that. So you've taken them from a very open, a very supportive learning environment to completely defensive, and everything's going to be cut off from that point on. So saving that negative reinforcement to a later time, I think, is key as well. One last thing before we move to the next one, the learning level of the student, that's the piece of the preceptor that you need to be adaptable and be able to have one student that you may have to be very basic. You have to go back to some of the initial training pieces versus that very advanced student that picks up things really, really well, that has great interaction with the patient. Really, really being able to choose how, just like we do with patient care. With patient care, sometimes we have to go down to a much lower level or a much more basic level when communicating versus a higher level. Same things with the students. It doesn't mean that one's better than the other. They just have different levels of learning. So the preceptor being able to understand that, recognizing and adapt their teaching to better accommodate the student. So what needs to happen as far as when you're at the bedside, what type of questions? They need to be open-ended questions as well as closed-ended questions. And it's kind of a hierarchy of knowledge. Questions should be at the appropriate level of a learner. And again, I just stated that. You have to be able to be adaptable enough and be able to recognize what level the student is. That comes with building that relationship. That comes with having open dialogue with that student. That comes with, you know, talking about things in life. That comes with talking in the halls, in the elevator, you know, building a relationship, not so formal. Have some very informal conversation before you get in the patient room so you can kind of see and judge where this student is, whether it's informal conversation about the football game or informal conversation about respiratory care. You can judge at what level you need to be for that student. The teacher must fulfill two roles simultaneously while you're in that teaching at the bedside piece, while you're in that patient room. And sometimes this can be something that takes some experience to really learn how to do. And you need to be able, the preceptor needs to be able to listen to the discussion of the presentation from the patient and the student and diagnose the patient's condition. We still are clinicians. We're still providing patient care. But we also, at the same time, need to diagnose the learner. So we need to be able to see where his or her strengths are, their weaknesses, and areas that we can improve on as they go through the process of whatever it is you're providing for the patient. So it's key, as you're doing these two things, still doing patient care, you still have to oversee that, it's your duty, but you're also having to diagnose your student. And there, in these moments are such teachable moments. You know, the huge what ifs, the whys, the what could you have done. Moments that can take place at the bedside while still providing comfort for the patient. Never making that patient feel uncomfortable. And so many times they jump in on that learning experience and they get excited knowing that they could actually teach the student something. But so, who knows their disease more than the patient themselves? We certainly don't. We don't live with it. So allowing them to be interactive in that usually gives a good response from the patients. So when you're looking at the bedside, and like I said, not every question and not every opportunity needs to take place at that bedside. There are some situations when you need to take it outside of that. Maybe something was done that you didn't need to bring attention to it right at the bedside, but certainly needed to address it directly after that. So where can you take advantage of this? Where's a teaching moment outside of standing right next to the patient? A couple of things certainly you need to be aware of is patient confidentiality, making sure if you're in the elevator that there are not other people around. If you're in a corridor, making sure it's not a crowded corridor where you're naming names or you're naming room numbers. A great place for this to take place is a conference room. And we do this after initial rounds or second rounds. We'll go to a conference room, and I've taken notes and go to that conference room, and we'll have an open dialogue between the students and ask what they saw and how they felt about this and what do you think you could have done, where do you see this patient going, and have just great communication, great open dialogue about what's going on with the patients and what can be done next. And a lot of times we're able to bring the medical records in there and actually reflect on things that happened yesterday and be able to predict things to come. So the conference room is a great learning environment. It's a little quieter. Often you're not interrupted by family members and other healthcare professionals. You can really focus on specific objectives. Teaching on rounds, there's some great pros and cons to this. The conference room, unlike the corridor or the bedside, seems to be more comfortable and quiet. When you're teaching on rounds in front of, out in the hallways and the corridors, there's some disadvantages to that as far as space is typically one of the biggest obstacles to overcome. If you have 4 or 5 students and you're in this narrow hallway and there's other healthcare professionals trying to push carts and blood pressure monitors and everything, EKG machines around you, so a lot of times you're in the way. So again, taking it to that conference room is comfortable, it's quiet, it's confidential. Time, you have plenty of time that you can discuss things that need to be discussed in there. And some of the disadvantages, again, you don't have the patient. If there's a question about a perception or something that took place, we're not right there to sometimes answer every question if we're not at the bedside. And it does rely on a presentation or a chart, and sometimes the presentation comes from the preceptor. So there's a lot of talking that has to be done from the preceptor, a lot of direction that has to be given in this conference room. Somebody's got to be the leader in the room. A lot of times, I'll allow it to be the student. It's a teachable moment for the student to be the teacher. Again, it works well with forming those memories and really learning, so it gives a great learning opportunity for students that are there and the student that's actually doing the teaching. Characteristics for the conference room, again, presentational skills, mini lectures. One of the biggest things that I think I utilize this for is pharmacology. A lot of times we're in a patient's room, and one of the things I ask them to observe is what medications they're on or drips that they have hanging. And so many times I think pharmacology is one of respiratory care's biggest weaknesses. We kind of go over it. The students seem to memorize it. They take the test and then they dump it. And so the next semester or the next year, being able to recall that information is often like, oh, really? Do I really have to remember this stuff? So these mini lectures, again, it's a great opportunity to say, okay, you have these 4 drugs that are hanging. Let's have some open dialogue about what these drugs are. And you have participants from multiple students that can give what they are. And again, it's teamwork. Forming relationship, and it allows them to teach. And then to be resourceful. If no one knows it, there's an opportunity there to pull out some books or pull out some things so that we find the answer to it. And it's not often that I'm going to give them the answer. All right? It's not often that that if I give you the answer, you're going to remember it for that second, and the next day it's gone. But if you go out and have to search for that answer and find that answer, it's more likely to be a memory. You're more likely to remember it and be able to recall it the next day. So team teaching is excellent, whether it's a team of the students, whether it's a team of different preceptors, or whether it's a team of other healthcare professionals. If it's nursing that I can pull in to help, maybe it's something I'm uncomfortable with, and I'll be the first to go and say, that's a great question. I don't really know. Let me go see if I can get a nurse to come in and explain this, if it happens to be a nursing duty. Or I'm not really sure. Let me go get radiology. I'm not real sure exactly what that means or what actually this procedure is. So bringing in other healthcare professionals, I think, is key in this part too. I'll tell you another thing, it brings respect. When you can sit back and say, I'm not an expert in everything and I'm not real good with this question, so let me find someone that is, so it can answer your question specifically and not so vague. So when you involve other disciplines, it builds that healthcare interdisciplinary approach, and it also builds respect between the two. Some strategies: keep task and time, diagnose the patient and the learner at the same time. Look for and capture teachable moments. You focus on the clinical problem skills. When you're looking at the clinical problem solving piece, a lot of times what we do in many academic settings is we talk about SOAPs. We have students write SOAPs, but when you're in the actual clinical setting, you don't write a SOAP. It's an application of a SOAP. So I think having the student go in and they find out why they're doing something, the objective, the subjective, allow them to explore both of those, bring it into this piece, and then what's the problem? What are we going to do about this problem? What would you suggest? So it gives a key piece to the why. To the why is that. Corridor, again, the HIPAA violations here you need to be very cautious about, but it does allow potential access to the patient if we go outside the door and questions that come up that really need to put your eyes back on the patient to be able to answer them. They're right there. It's quick. Just make sure patient confidentiality is respected and the HIPAA violations are not even, that you don't violate any of those. Some of the disadvantages can be uncomfortable. Again, that distracting, noisy piece, because if it's a large group, you're going to be in someone's way. And the confidentiality piece. If it's something you can keep, especially if it's a one-on-one, one student per one preceptor, it's a lot easier to do this. You can be a lot as far as the tone of your voice, the level and volume of your voice. There are a lot of things that can be discussed that's just between two people instead of a group of people. Corridor can be, you can take advantage of that in multiple opportunities. And so the what ifs and the teachable moments can exist many, many times in a corridor if it's just one-on-one. Some advantages for directly at the bedside, you have that contact. Again, you can bring that patient in. You can hone in on the skills of the patient, the symptoms, what the patient has to give to it. A great moment for a patient to teach a student something is something that the student takes away. Great knowledge and perception. It's almost a testimony. So that testimony from the patient is something that a preceptor can't give. And many, many patients, most of the time, are often open to this. They love to participate in that. They feel like, they're still able to do something while they're lying in the hospital bed. It allows clarification on the history, the HMP, allows teaching of the history and physical. So if you just read something in the chart that said, something about the occupational history, they worked in the plant for all these years, and this is the reason for their disease process, and you go in and ask that patient, well, I see in your chart that you worked at a cotton factory for all these years, or wherever it may be. How long did you work there? So it creates a moment of open dialogue and great relationship building between the student learner and the patient. Again, it brings a sense of comfort. It allows them that interaction. And another thing that you can do as a preceptor is role modeling. When a student sees you do something, it's kind of like a parent-child. You are mentoring them. You're doing what you're doing, they're going to follow. Role modeling is key. Again, do one, teach one. They're key for students. If you role model something, if you have students multiple times, many of your habits they're going to pick up. So if your habits are good ones, they're very conducive to learning and patient care, that's a great thing. And that same student's going to go with another preceptor and say, such and such, Susie, did it this way, you must be doing it wrong. So having that moment with the student to say there are multiple right ways to do things, but there's always the wrong way. Let me tell you what's wrong. Let me tell you the wrong ways to do things. So just because this preceptor did one thing one way and this preceptor did it another way, there's so many multiple right ways to do things. So I think that again is key to bedside teaching. So overcoming time, set aside time to teach at the bedside. Bring the learner on routine patient visits. And there's a time when you need to take the moment to wrap it up and take it outside into the corridor, and there's a time where you need to have the teachable moment right there with the patient. Make sure you can recognize those and utilize them. Concern for the patient comfort. Always speak with the patient first. If the patient is conscious and alert, and see if they're okay, especially when you have more than one student. That seems to become the level of concern for patients when they have multiple students or groups of individuals coming in. So always have that conversation with the patient, let them know what you're doing, and they're going to be it's going to be supportive, and they're going to be a lot more comfortable with it when you have a conversation prior to entering the room with 4 or 5 students. Concern, again, all examinations procedures should be explained just as in when you're given typical patient care. Discussions and communication should be explained and understandable at the level of the patient as well as the learner. So if you know you're putting it at the level of the patient, and you're doing that perception of how, a lot of times it's nonverbal, being able to read if that patient is understanding what you're saying, it's going to allow that student to understand as well, and also to be able to learn ways to think, okay, this is how I need to communicate with a patient. All right, getting started really quick, you have to start small. Use the material you have, and there are multiple ways to do this. Involve the learners. Review your own physical exam skills. A lot of times that psychomotor piece, when you're riding a bicycle, you just do it. There's no thought process to it. So as a preceptor, you have to take it in phases so that you can explain what you're doing to the student. Don't just assume they know, because you've done it 100 times and it's repetitious to you. It's not repetitious to them. It's not something that they understand and they know. Some of the other locations that you can utilize these teaching at the bedside, it's not just in an acute care facility. It can also be in a nursing home, a long-term care facility, and also the outpatient setting. And one of the best places I think for that is pulmonary rehab. So many times we utilize education pieces in pulmonary rehab where you have student learners as well as patients. And boy, those patients really love to get in on the education in that. Their testimony is truly key in the growth of the student. So to summarize everything and attempt to wrap this up, a valuable form of clinical teaching is at the bedside. It's where you're taking what you've learned from the books and you're applying it at the bedside, and you're having open dialogue about it. You're still able to be aware of the student learner and have awareness for the patient. So you're involving everyone. You should feel better after the teaching session. Everyone's gained something. And one of the key things that you need to remember is have fun. This is your life, and if you enjoy it, a smile always brings comfort to the patient as well as the student. And I think it's key in the growth of everyone. Thank you so much for coming out today and listening to this. There are many other opportunities for preceptors to grow and to help give support as schools begin to do more with less, and utilizing preceptors is something that we're all going to have to do, and I hope and it's a good way to find and identify individuals out there that can make a huge difference in the future of our profession.
Well, Susan, I want to thank you very much for an excellent presentation, a great overview that applies not only to teaching students at the bedside, but as one of our people attending today said that they believe that the presentation is also appropriate for orientation of new hires, things like that. So I think you've given us an awful lot to think about today. We don't have a lot of time left. We have a few questions that have come in. Those of you that have questions, I suggest that you get them up on the chat board right away, and we'll be monitoring those and try to address those. But in the meantime, what are your one of our participants wants to know your thoughts on the benefits of adult students being under different preceptors during the same clinical rotation.
Okay, Bill, so just to review the question, how I feel about different preceptors for the same student learner?
Yes.
Okay, I think it's great. I think, and that's one of my goals here, is to give a student multiple preceptors within their time frame here, which is 2 years. The reason for that is it's a diverse knowledge. If I'm learning about the way I do something and the way that you do something as a student, then I'm going to walk away having insight from 2 great ways. So I think having a huge preceptor pool to pull from is an excellent opportunity for the student learner to be diverse in their knowledge.
Okay. One of our participants wanted to know about asking about the presence of students at the bedside. Are there any special considerations you make? Do you ask the patient for if they mind having a student at the bedside or anything like that?
I always tend to, if I'm going to have more than one student with me, I'll always have a conversation prior to entering the room with a group of students with the patient and ask them, hey, I have a group of students here, and I'll let the patient know what level learner they are, if they're an early respiratory therapy student or they're in their late phases. And sometimes that brings more comfort to them as well. Before I bring the entire group in there, I don't want the patient to be uncomfortable. And there have been times when the patient says, you know, I'm not comfortable with students, or I don't feel like dealing with that many people right now. Can we keep it to just one? And of course, you know, that's exactly what I do.
Okay. Do you always interact with the patients before they see a student, or might you have a student go in and introduce themselves as a student to do a procedure, for example?
Initially, if they're early in their learning experience, yes. If they're not, no. I do not like, I'm not sure if this is a politically correct way to say this, but I do not like to utilize students as worker bees, having them a task of Janet's and saying go out and do it. No, I don't think that allows, there's a lot of liability there. However, if the student has become comfortable in doing certain procedures, I will allow them to do it while I'm not in the room. I could be outside in the hall. I'm in a reachable distance that if they need me, I'm there. And a lot of times I'm in the background. They don't even know I'm there, so that I can hear and listen to the conversation. I'm not their shadow. But I'm never going to be on a different hall. I'm never going to be on a different floor. I'm going to be accessible to them.
Okay, great. Well, I do not see any more questions rolling in. If you wouldn't mind, Susan, just go over to the chat box and go to the very bottom and work your way up and see if there are, oh, here's some questions. See if there's anything there you can address in just, we have 1 or 2 minutes remaining.
Okay, I'm looking.
Yeah.
I said one of them, any suggestions for the students, including experienced therapists, using translation phones? I don't have any experience in that. One of the things that we do have here, because this area is fairly diverse and continuing to grow, we have specialized training in the hospital for certain people that we access to use as translators. Trying to find some other questions that I see real quick. One question here is, did we mention anything about asking the patient or the healthcare proxy as a applicable permission to have a student at the bedside? If the patient is not capable of answering the questions or is unconscious and the family member is at the bedside, yes, I do interact with the family member. And here one of the things that we've attempted to do is have that family and the patient learning experience. So if I can bring the family in, often I do, because the family is so undereducated many times when it comes to health care, even just the terminology. So even talking about typical diagnosis, names, things that they hear that they have no idea, it's a great moment for the student to say, oh yeah, PRN means this, something that's so trivial to us that patient truly or the family members have no idea what the meaning is. So even those are teachable moments.
Okay, well, we're going to have to wrap it up for today, Susan. Again, I thank you for a wonderful presentation, and for those of you that are watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this is the end of our presentation.
Thank you, Bill.
You bet.